Okay, so I'm going to answer some of the questions, or at least try to answer some of the questions that were sent in response to this webinar. The first question is, are there any studies on ages at which patients develop spasmodic dysphonia? There are some case series where people have asked that question of the patients in their clinic, and the average age seems to be around 45, between 40 and 50 years of age. However, some people develop spasmodic dysphonia earlier, and that usually happens when there's a family history of spasmodic dysphonia. The second question was, has trauma, physical or mental, been studied as a cause of spasmodic dysphonia? There have been questions in some of the questionnaire studies that I talked about, asking whether trauma, either physical or mental, whether people reported that. The problem with those kinds of questions is that everybody organizes their life according to physical and mental things that happen, stressors that happen in our life. That is divorces, loss of a family member, sickness, severe illness. And so often when we think of the cause or the beginning of a disorder, we tie it to the other events in our life. And that doesn't necessarily mean that it has anything to do with it. So this is a very difficult issue to address by asking people about it, because our memories peg things according to these kinds of events, and they may have nothing to do with them. The next question is, have any of the studies found that patients report that their spasmodic dysphonia started after surgery due to issues of intubation? And was this question asked during any of the studies? Yes, that question has been asked, and there are voice disorders that not often, but can be associated with intubation, but spasmodic dysphonia doesn't seem to be one of them. There can be some injury to some of the nerves, but usually people with spasmodic dysphonia do not have nerve involvement, and there can be injury to the tissue, and again because of prolonged intubation, and again that does not seem to be the case in the people who have spasmodic dysphonia. So to date there doesn't seem to be any association between intubation and the onset of spasmodic dysphonia. The next question, do any researchers theorize that spasmodic dysphonia is a learned or compensating response that people have developed after recovering from a virus or other illnesses? That we don't think is the case. There are other voice disorders where people learn to produce a compensatory response, such as muscular tension dysphonia, where patients through therapy can often reverse that compensating response. So we don't think that's the case in people who have spasmodic dysphonia. However, I should mention that some people develop some muscular tension dysphonia in their attempt to compensate for the symptoms of spasmodic dysphonia. That is that they develop some tension in their laryngeal area in trying to steady the voice and overcome some of the spasms. So we don't think that compensation is a cause of spasmodic dysphonia or it predicts spasmodic dysphonia, but rather that can be a response to spasmodic dysphonia. In the next question, in the initial portion of your talk you discussed change over time, and people wanted to know whether the percentages that were presented as improved, unchanged, and worse applied to only those without treatment. No, this applied to everybody in their patient group, so this applied to both people with and without treatment. So the next question is, what if a grandmother or great aunt that had voice disorders are gone, that is, have passed away? How can you determine whether it's a genetic disorder? Well, to examine for genes that might be affected in people with spasmodic dysphonia, usually they want several people in a family who are not closely related. That is, that they should be from different generations or from different parts of the family. If they're not closely related and there are still some genes that are common to these people who have spasmodic dysphonia, then they can better identify the genes that might be related. Whereas people who are directly related often have very similar gene composition, and therefore it would be difficult to determine what might be simply because they're related or what might be because they both have spasmodic dysphonia. So it's better to have people who are in a large family but separated in different parts of the family. The next question, does the severity of spasmodic dysphonia correlate in any manner to the difficulty of obtaining treatment for the disorder? That is, are more severe, I guess what they're asking is, are more severe people more likely to have difficulty in obtaining treatment for their disorder, or the opposite side, are less severe people, people that have less severe symptoms, having more difficulty? That's a good question. I don't think it's been thoroughly addressed by researchers. It seems that people who have more severe symptoms sometimes find a greater benefit from treatments such as botulinum toxin injection, whereas people who are milder in their symptoms sometimes have more of a trade-off. That is, their improvement is less in compared to some of the side effects such as breathiness and swallowing disorders. So we do think that sometimes when people have less severe symptoms, botulinum toxin might be hard to find the best dosage for them because they get some other side effects. Then the next question, which is probably a very important question, what's the difference between spasmodic dysphonia and muscular tension dysphonia? And how common is muscular tension dysphonia secondary to spasmodic dysphonia? Well, first of all, what's the difference between spasmodic dysphonia and muscular tension dysphonia? One is that spasmodic dysphonia, as denoted by the name, is irregular. That is, people have breaks at different times in their voice, that their voice is irregular. Sometimes they have breaks on some sounds, but other sounds are fine. And so it's spasmodic, as the name denotes. Whereas people with muscular tension dysphonia tend to have a constant tension in their voice. They don't have breaks, and they tend to have this constant effort and tightness all the time when they go to speak, and doesn't change according to what the sounds are that they're trying to say. How common is muscular tension dysphonia secondary to spasmodic dysphonia? I think that's pretty common. It's certainly in the patients that we've studied in the study that we're doing right now, we find about a third of the patients have muscular tension dysphonia secondary to their spasmodic dysphonia. That is, they have both voice disorders, probably started with symptoms just of spasmodic dysphonia, and then in attempting to compensate, develop some muscular tension dysphonia. The next question is, where do we stand with variations of Botox for treatment? There are different types of Botox now that are available, and some are type B and some are type A. And we really don't have any studies comparing these different types. We do know generally in other types of disorders, not spasmodic dysphonia, but in other types such as cervical dystonia and blepharospasm, that the type B doesn't seem to last as long as the type A, so that may be one of the differences. But if people stop responding to one type, then it's good to have another type available. The next question is probably another very important question that many people ask. Why are my results so variable with the same dosages of Botox? The answer is we really don't know. Some of the exchanges between different physicians who are providing this treatment suggest that maybe the disorder responds differently to the Botox. Also, it's difficult to put the botulinum toxin in exactly the same place in a muscle. Also, different physicians use different techniques, and that can be variable. So if you're going to different physicians, you may find that you need different dosages because they are doing the injection in different ways. But we really don't know the answer to that. We do know that some patients, their disorder seems to adjust to botulinum toxin over time, and that changing the injection techniques can sometimes help them to get better responses. So it seems that maybe the disorder sort of starts to go around the effects of the botulinum toxin. But we really don't know the full answer to that, by any matter it means. The next question, are surgical techniques improving? We do have different surgeries, such as the SLAD surgery that was developed by Dr. Burke, and that's different than the recurrent nerve surgery where they used to section the nerve on just one side of the larynx. The SLAD surgery seems to be much longer lasting than the previous kinds of surgery that people did in the 70s and 80s, where they just cut the recurrent nerve on one side. However, we really haven't had good long-term studies of the effects of surgery, so I think the answers to that question still need to be determined, and we need more studies. There are more physicians doing that surgery now, and so we probably need multiple centers to be able to look at the effects of surgery and across different physicians doing the same procedure. So we still need a lot more work to find out the answer to that question. The next question, are there any studies looking for treatment options for abductor spasmodic dysphonia? That again is a question that we really don't have the answer to, and is unfortunate because patients with abductor spasmodic dysphonia, as you know, are fewer. Fewer people seem to have this form of spasmodic dysphonia, and therefore it's difficult to do studies of treatments. Botulinum toxin into the posterior cricoarytenoid muscle doesn't seem to be as beneficial in as many people with abductor spasmodic dysphonia as injection into the thyroarytenoid muscle in patients with adductor spasmodic dysphonia. So we clearly do need other treatment options in the abductor spasmodic dysphonia type, and probably the need is to add additional treatments such as medications, but people really haven't started studying that. So stay tuned. What are your thoughts about other types of spasmodic dysphonia that have been described besides adductor, abductor, and adductor-abductor? Should they be considered in current spasmodic dysphonia literature? That's a very good question. We're finding that that many patients probably have adductor spasmodic dysphonia plus tremor. Others have adductor spasmodic dysphonia plus muscular tension dysphonia. And that's probably like the tensional spasmodic dysphonia that we've seen. Some patients have tremor alone, and they can have tremor affecting the diaphragm, and that may be the basis for some where we talk about respiratory involvement in spasmodic dysphonia. But I think we're still finding that spasmodic dysphonia consists of the adductor type, the abductor type, and the tremor component, and patients seem to have different combinations of those. And then there's, of course, there's also some of the muscular tension dysphonia that develops as a compensatory mechanism. Some of the studies that we're doing now that I described at the end of the presentation, talking about trying to come up with lists of the different symptoms for the different types, I think will go a long way in the future to address the questions of how we should classify the spasmodic dysphonias and how we should label different types. That's very important if we want to look at different treatment approaches in the future. So that's addressing some of the questions that we received, and I think that's the end of this segment.